Good afternoon, everybody. May I take the pleasure of introducing somebody who doesn't need any introduction in any spinal oncology meeting anywhere in the world. Let me just say a very honest fact. And it's a great pleasure to invite Dr. Boriani, who's based in Bologna in Italy. And I'm sure we've read a lot about his work, and we've all heard a lot about his various talks on different things about spinal oncology. I think I won't waste any more time. I think the numbers on the right-hand panel with participants says it all. So, so many have stayed back virtually late on a Friday afternoon to listen to this talk that we're going to hear from Dr. Boriani. So, Henry, can we play the talk, please? Thank you very much. And I would like to, one more thing. I'd like to thank BritSpine for helping us put all this together. Sorry, great, thanks.
It's really a great privilege for me to be here and share with you my experience in block resection in the spine, which is indeed a very interesting surgical procedure. And I would like to point out especially advantages and disadvantages. Here you can see my disclosures that does not affect at all what I will tell you, what I'm trying to state and to stress. And these are my learning objectives. First of all is to point out that Enbloc resection is an oncological procedure. So we can be orthopedics or neurosurgeon, but to perform Enbloc resection, an oncological training is mandatory, especially in the spine, where the indication and the criteria of feasibility are restricted and must be very well known. And what is more important, I would like really to share with you, as the decision-making process is really mandatory, and we have to balance the oncological advantages of the surgery versus morbidity or functional loss. So let me start since the definition, in order to be clear on the term that we are using. So we mean that for Enbloc resection, a whole tumor resection encased by a continuous shell of healthy tissues. This is very important, the so-called margin and its thickness. The thickness of the healthy tissue around the tumor is really qualifying the oncological validity of the surgical procedure. This has been demonstrated in the literature. We have done a paper many years ago demonstrating that the rate of local recurrence when performing anything non-appropriate surgery, it means that the margin has been violated, is about 10 times higher versus the local recurrence rate when anything appropriate surgery is performed. This is also the result of a study performed by Fisher many years ago, where he found that there is a statistically significant less incidence of local recurrence when anything appropriate surgery is performed and also morbidity is affected. So let's see some interesting cases. For example, this is a case of chordoma, and when Enbloc resection was performed, you can see that it is clear even from the surgeon's perspective, that there is a focally intralesional margin, and this corresponds to the local recurrence that we have to expect and will occur 3 years later. So the question we want to face now is what can happen when the tumor, especially chordoma, is extracompartmentally widely invading the canal and the psoas muscles. You see that when Enbloc resection is performed, there is many areas of violation of the margin. So what will happen to this patient? But I would like to start since the beginning again. So there are 2 questions when planning Enbloc resection in the spine. When Enbloc resection is appropriate and when Enbloc resection is feasible. These are 2 questions that we must answer before starting this procedure. Appropriateness is based on margins, on the margins required. It means that any Enbloc resection is appropriate for chordomas, for example, but it's not appropriate for maybe aneurysmal cyst, for myeloma, for other kind of tumors which are not according to the Henneking staging system. But feasibility is dictated by the anatomical constraints, by the tumor extension, and it's not sure that Enbloc resection is feasible in all the cases. Any staging system dictate the appropriateness of Enbloc resection. Enbloc resection is feasible, and it demonstrated to be very useful in aggressive benign tumor like huge osteoblastomas or giant cell tumor, low-grade malignant tumor, stage 1, you can see here on the right. But in stage 2, high aggressive, high malignant tumor, chemotherapy and radiotherapy are mandatory together with Enbloc resection, which otherwise is not feasible enough, is not valid enough. Feasibility. So feasibility means to perform Enbloc resection valid from an oncological point of view, and possibly without creating unacceptable anatomical sacrifice. For example, we need at least 3 sectors of posterior arch free of tumor in order to enter in the canal to separate the dura from the tumor. Otherwise, like in case like this, where the tumor is concentrically growing all around the canal, if we want to perform a oncologically appropriate surgery, we must sacrifice all the content of the canal. It means that this young patient with an osteosarcoma of 4 vertebrae after chemotherapy has been submitted to Enbloc resection, including the cord, and again chemotherapy. This is the resection, including 5 vertebrae together with the cord. So it's clearly a very severe functional sacrifice, but the patient is surviving after it was performed in 2004. So 16 years that the patient is surviving, and this is a very good result for an osteosarcoma of the spine. Obviously, she is paraplegic. And this is what we find out from our series of osteosarcoma on the spine. You can see that only when Enbloc resection was combined with complete chemotherapy, we could have an acceptable rate of local recurrence and a good final outcome. On the contrary, conversely, if we perform Enbloc resection but without chemotherapy, then the local recurrence and the outcome is very bad. The same as you could perform intralesional excision together with chemotherapy and radiation. So it means that the chemotherapy control protocols do not make appropriate intralesional surgery, but conversely, Enbloc resection has few possibility to be appropriate if chemotherapy has not been fully performed. So an oncological approach is mandatory to treat this case. And obviously, never such a huge sacrifice to be proposed to the patient, but for example, in this case of an osteosarcoma of L5S1, to perform an Enbloc resection, we must consider the invasion of the canal, the invasion of the sacroiliac plexus, of the iliac vessel. So when performing Enbloc, we have to include the dura here and sacrifice the nerve root inside the foramen, and also replace the iliac vessel with a graft. And this is a case of recurrent chondrosarcoma. So there is a scar inside the canal connecting the dura with the tumor. And so to perform an Enbloc resection with a good margin without violating the tumor margin, we have to resect the dura, and the dura in this case is the margin of the tumor in this area. The other point is the feasibility on a technical point of view. It's not true that Enbloc resection can be performed only by one type of surgery, like Tomita, for example, work a mill. In many cases, if the tumor is anteriorly located or eccentrically located, or the tumor is very huge anteriorly, if we do just the posterior approach, we violate the margin, we enter in the tumor. So I think that planning should be decided according to the anatomical constraint and the tumor extension. And to this purpose, we have used the WBB staging system to propose a staging of the Enbloc resection, which was recently published. And we have proposed 7 different strategies combining anterior approach with posterior, only posterior, 3 approaches. So it depends from the tumor extension and for the anatomical local constraint. But it is not the topic of this speak. The topic of this talk is, on the contrary, to beware about this kind of surgery before deciding. This is a very demanding surgery from a technical point of view. It's time consuming, blood consuming. It's associated with high morbidity, with a certain kind of mortality, of intraoperative or perioperative mortality. The complication rate level is very high. It requires long rehabilitation and last but not least, very high costs. In our series we published some years ago, we found a complication rate of 45%. It means 153 events, and sometimes events are like a cascade, and one create another one, and in some cases even 4 or 5 complications in the same patient, and 7 patients died due to the surgical complication. The good news is for many patients, this kind of surgery means a final healing. We have 23 patients surviving more than 15 years and 49 patients more than 10 years. So even if 7 patients died of surgical complication and 63 died for the disease, many of these patients take a great advantage of this surgery. For example, this is a young woman which was submitted to Enbloc resection of L5 chordoma, which is a very difficult surgery, meaning 3 approaches, first anterior one side, then posterior, then combination anterior and posterior, in April 96. She is still surviving after 24 years without any evidence of local and systemic disease. This is another patient operating in February 10. This is another huge chordoma involving 3 vertebrae. We resected 3 vertebrae and 2 segments of above and below vertebra, and Enbloc resection with a good margin. And he has 11 years follow-up without any evidence of disease, with an excellent quality of life. But notwithstanding the evidence that Enbloc resection, with when feasible, has excellent results, the spine community is still reluctant to fully adopt the principle of musculoskeletal oncology. I don't know why, but in cases like this, for example, this patient had a L3 chordoma, which could be really relatively easy, submitted to Enbloc resection. She was just submitted to intralesional partial excision, and this obviously result in a local recurrence. She was referred to us with this recurrence, huge. She was submitted to Enbloc resection, but notwithstanding that, the result was very poor. And she died 9 years later, but very, very, very bad quality of life. 7 local recurrence, radiotherapy, chemotherapy, imatinib, but this did not prevent the worst outcome. The complication, indeed, of this surgery is very well known, that it is high. That there is no doubt about that. This is a systemic review performed by the Spine Knowledge Forum recently, and we found the complication rate in sacral tumor up to 100%, and the complication rate on mobile spine up to 74%, with a substantially number of patients that can die during surgery. But on the other side, we have several reports of very good results. This was published by my mentor, Christian Mazel. 120 Enbloc resection, 25 patients surviving more than 9 years, with a quality of life which was similar to the French general population. And these are some other reports from Alessandro Lussati, another expert in Italy, in 130 Enbloc resection with 38 multilevel resection. The majority of patients recovered from their complication and enjoyed a long life. And even if we separate from the younger patient to the elderly, we just see that the rate of early complication is higher in the elderly. But in any case, the majority of patients enjoy of this surgery, which saved the life of this patient. Especially in young patients, we have a problem that if we perform an Enbloc resection, for example, in the Ewing sarcoma at the age of 9, the growing spine we try to save the movement, so we do a short fixation, but in most of the case, we have later on to face the problem of the deformity. So excellent result from an oncological point of view, but we must to restore the correct alignment later on. This is the most frequent complication in the younger patient. But going back to the prognosis and the indication related to the histology, let me show you that for chondrosarcoma of the spine, Enbloc resection with a good margin is most of the times very successful. You see that in 15 cases where the margin was respected, no local recurrence and no patient die. And the difference is clear when the margin is violated. We have about 25% of local recurrence, and this patient will die. And when interlesional surgery is performed, the result is even worse. For chordoma, indeed, we have still a big problem, as even Enbloc resection, which is declared by the pathologist as the best surgery ever performed, a good margin, we can expect, however, about 30% of local recurrence. And this is still an open problem to be faced. So for chordoma, we must conclude that local and systemic control is positively affected by tumor-free margin resection. Margin violation is associated to result comparable with intralesional surgery. This is a very important statement. But the problem for chordoma is still that the tumor-free margin resection can seldom really be achieved in chordoma, which are some huge masses, soft, difficult to manage and to manipulate. From this paper recently published, we one more understand the problem of the treatment of recurrent tumor, as the margin of salvage surgery do not impact on patient outcome. So all that I told you till now lose any importance when a patient has been already treated. So the first treatment really affects the prognosis, and the salvage surgery, as you have seen in the case I showed you before, in the best Enbloc resection, really has not the same result as on virgin patients. So what we can do, what we can offer to patients who have been already treatment without fulfilling oncological principle. Let me show you two very similar cases. On the left, in yellow, a 62 years old woman with L3 recurrent chordoma. On the right, in white, a 50 years L2 recurrent chordoma in a male. And in this patient, we did perform an Enbloc resection, isolating the vessel by the anterior approach, and then resecting everything from posterior, from the skin to the whole vertebra, sacrificing the cauda So trying to achieve the best oncological resection we could achieve with a good margin, obviously sacrificing all the content of the canals. The patient is paraplegic, but the oncological principle was fulfilled, and we hope that the patient will survive as long as possible. Now we have a 2 years follow-up without any evidence of disease. On the other side, this patient had some cardiovascular problem. He had arrived to this situation after very bad surgery, not absolutely concerned about the oncological principle. They did a vertebroplasty in a chordoma, which is absolutely stupid thing, with just a fixation and decompression. So the result with such a huge tumor. So we decided to try to refer the patient to the radiotherapist once reduce the tumor mass and relieve the dura with this separation surgery, which is a less aggressive surgery. We use carbon fiber system to allow proton therapy. So for some time, so we were very happy as the tumor mass remained the same, but after some months, we are facing a huge tumor recurrence, which is, it is not a recurrence, it is indeed a progression, which requires a surgical revision. So comparing the two cases, in one there is a very high morbidity surgery with a severe functional loss, with an expected local recurrence about 30%. On the other side, separation surgery, low morbidity, no functional loss, but progression of the disease at short middle term. From a financial point of view, It costs much more, obviously, than block resection, but if we combine with the cost of the radiation, we arrive almost to the same price. So the two possibility are at the same cost, and it's still very difficult to decide which is the best. As a conclusion, let me report a very recent case report by Diego Kaslan, who is in the group of the BritSpine Knowledge Forum, one of the major world experts in the treatment of bone tumor, is reporting of this very huge chordoma in the cervicothoracic spine, and he did use the best of the state-of-the-art possibility. A team including neurosurgery, thoracic, head, neck surgery, plastic surgery. He had also the support of medical and radiation oncologists, rehabilitation team, and he used the 3D printed models and the intraoperative CT scan, stereotactic navigation. The result was, after a 2 days surgery, a tumor-free margin and block resection. You see very huge tumor with the so-called intact tumor capsule and negative margin. But this patient experienced some complication, ileus, atrial flutter, upper limb weakness, ischemic optic neuropathy, was readmitted for debridement for an infection, pulmonary edema. At 1 year, there are persistent neurological deficit and still local recurrence. So really very difficult to decide if this really was a successful operation, but his comments are very useful and should remain as a very good standpoint for designing. So he said that despite all the effort, all the technical possibility, the patient had morbidity and local recurrence. And so the decision-making process, even if you have the best technology at disposal, you must remember that long-term oncological outcome can sometimes be similar to that following a less morbid single-stage intralesional resection, especially in such a huge and extra-compartmental chordomas. Many people believe that any surgery, whether appropriate or not appropriate, but combined with radiation, will likely result in higher local control rate versus surgical resection alone. This is the result of a systemic review performed by the Knowledge Forum, but indeed is not yet our personal experience, even if it at the moment is the best solution. But in the literature you can find also some pessimistic statement like this published on the Lancet Oncology. There are few reports of treatment protocol and outcome for recurrent lesion, or even patients who recur locally are unlikely to be cured by any local salvage treatment. So as a conclusion, my take-home messages should stress again that Enbloc resection is a procedure of surgical oncology, so we need to be specifically trained on oncology, on the behavior, on the tumor we are treating. The advantages of Enbloc resection is a higher local and systemic disease control, but only if the oncological margin is achieved. The disadvantage is that the feasibility criteria must be fulfilled. So for huge tumor, when the contamination can be considered, the indication is not really the best. There is a very high morbidity with possible loss of function. So the decision-making process is very important. The new technologies are just a tool, as our target is the oncological appropriateness, as we must always remind that a local recurrence will negatively affect the function and the life expectancy. So the first decision affects the final prognosis. We take a very heavy responsibility when deciding to perform an Enbloc resection or not in a patient with this kind of tumors for those who are only one-shot surgery. So thank you very much for your attention, and I am available for any question you would like to address me.
Thank you very much, Professor. It looks that Sachin is offline at the moment, and Mel and Jeremy are due to join us. Sachin is back on, so over to you, Sachin.
Martin, I'll let you moderate this. I'm just in the background helping with the admin. Go for it.
Thank you very much. We're waiting for Mel and Jeremy to join us. Professor, it's an impressive work of yours, inspiring generations of surgeons. We've been discussing the impact of genomics and proton beam therapy onto the spinal oncology. What's your take on these two topics that are quite hot at the moment and believed by some to change the landscape of spinal oncology within the next 10, 20 years?
Well, I don't know so much about genomics, but it is a great hope. As I think that there are many questions today for chordomas that have no answer. And this tumor is different from the other. As chondrosarcoma is relatively easy to manipulate, and even if it is a huge tumor volume, we can work around it. We can manage to have a good margin. But for chordoma, when it is huge, when it is extra compartmental, really even the pathologist write to us that the margin is intact, but this is not true, as this tumor is something like a jelly tumor, and I think in most of the case of huge tumor, we miss part of the tumor, and the tumor will start again soon. And I think that we have no real possibility today to save this situation. And the great hope is indeed on genomic. And I'm following the evolution of the studies, and I hope that they will give some answer. Indeed, we have a very close relationship with people working with the oncologic radiotherapist. They do their best. They use great technology, but after some years, the tumor is still there and starts growing again. So I don't think that indeed is a real solution. I really do not believe that radiotherapy associated to surgery really improve the final outcome. At least in my experience, it doesn't happen. What I can do from my experience is that whenever we succeeded to perform an Enbloc resection with a good margin, which is not common, which is rare in chordoma, then the result is good. Anytime that there is any doubt, any violation of the margin, no hope. There will be a recurrence, and it will be a disaster, as I showed. So let's hope they will give us some answer in the future.
Hi, Stefano. Great to see you.
Hi, Jeremy.
Hope you're well. I think that there are certain tumor locations that seem to suit well surgery, and then other tumor locations that seem to suit it poorly in terms of local recurrence. And I would say the sacrum is a different beast than the mobile spine from a technical perspective, that I seem more lucky, shall we say, when I'm operating in the mobile spine than I'm operating in the sacrum. And I know you have some experience now with just sending patients for carbon therapy in the sacrum. Is that something which you are reversing a little bit, that you're finding that it seemed to hold the line for a while, but now the patients are coming back with disease progression at 5, 6, 7 years? Or is that something which you think is still a treatment option?
This is you are right. This is a time limit problem. As 3 years ago, I would have tell you never operate again on sacrum. But now we are seeing patients treated 5 years ago. They have necrosis, they have fractures, they have tumor growing, they have pain, and then operating now is much more difficult. And so you send the patient back for radiation. So as I told you before, this is a question without answer at the moment. And I understand if I had a chordoma in the sacrum, I would prefer to have proton therapy before surgery, but now I know that it's just a question of time.
Yeah, I think that was kind of always my suspicion. So if in a 40-year-old, you probably
Jeremy,
want
can
to
I just
shop.
interrupt? Kath Coyle
Yeah.
is online in this chat, so Kath could help us out with that.
Oh, I think she disappeared. Yes.
Yeah, I'm here. I'm here.
Great.
No, I do agree. I think that when we've had patients who are young, we have been through the panel, because we have a national proton panel. We've been very worried when some patients have been sent to us that are relatively young with a view to definitive protons, and we have really questioned whether protons alone for that group of patients is appropriate. As you can see, we do have a small but growing number of patients that are receiving definitive treatment, mostly to the sacrum, very few to the mobile spine. But in those patients, it's because the tumours, when I say they're inoperable, I don't mean that they're technically inoperable, but that they are really, the operation is so unpleasant. So I think I mentioned that this morning. We've been outlining a patient who's 31, and there's been a lot of discussion about that patient, a lot of discussion with the surgical teams. So I think if you've got somebody in their 70s, you can feel, and it's a reasonably sized tumour, I think you can feel reasonably comfortable that they will get local control, probably within their natural lifespan. But once they're starting to be, as we've seen very recently, which may be COVID related in terms of the presentation and delays, you start to see patients that are being referred to us in their 50s. We'll push back and say we would rather do a combination, and we would like to do the 19.8 and 11, and then the post-op, and right up to 70.2. As I also said, we've only got 2 years of experience as of yet. Therefore, our only recurrence in all of our patients has been a patient with a rhabdomyosarcoma of the head and neck. We've had no recurrences yet in the spinal cord, but we're just waiting. But again, we've got these very big tumors. We're doing much more aggressive treatment, perhaps, in terms of getting the treatment spot on, because at Canal, when I was in Canal, they don't have onboard CT for all of their carbon beam. They do replan quite a bit, but I mean, we replan a lot. So we'll see, but yeah, I'd agree. I wouldn't be. It really is a pushback discussion about having the combined treatments rather than definitive alone. But as for genomics, I'm sorry that I missed that talk because I was at our college meeting. I think in primary bone sarcomas, there'll be limited use of genomics, only because there'll be a limit. It'll take so long for a useful drug to be found. And the problem with genomics now is you can have genomics for this, that, and the other, the whole gene sequencing. Sometimes you can come out with drugs or with tumors where it says, oh yeah, you might have a response to some drug that isn't even licensed or licensed in that use. And that becomes quite a murky area. And some of the area that's currently under legal, what can I say? Yeah, legal in with that one practitioner in London. But yeah, that doesn't mean that we shouldn't gather all the data, because maybe something will come out of this later on. As you know, there's the MPNST international, trying to get those cohorts of patients coming through. Primary bone sarcomas, a lot of actual genomics that is going to make a difference within the next few years, less likely. Prostate cancer, maybe for a very small number of patients with BRCA, which might influence SABR, might influence your surgery, because there is a drug for that.
We were saying, Catherine, earlier that the genomics side of things and the immunotherapy side of things is just something really, for most people calling in, most people are not working in a sarcoma center, but do have obviously to be aware of sarcomas because they are dealing with metastatic cord compression, that may be a solitary lesion, that might be chordoma. So for exactly what we've talked about in terms of awareness, these talks are very much about creating awareness so that we don't end up with mistakes. And one of those mistakes could be to take somebody with multiple metastatic disease and not offer surgery that then ends up with permanent cord compression, low Konofsky status, low performance status, that then prevents them from going for immunotherapy that could actually have given them disease control. And that bit, the spine surgeon, in the general spine surgeon, might sit at the front of that spear. And that's what I think has been great about this afternoon's talks, is that we've gone through the sort of sequence that says, look, everybody, this is a really more complicated area than perhaps you might think it is, that a nihilistic approach to it can create really big problems without a little bit of extra thought, and that there are plenty of people around to contact and to communicate with to maybe steer away from something which then can't be undone. And I know Stefano comes from a country where a huge chunk of what Stefano does is revision surgery. That's right, isn't it, Stefano? It's something like 70% of the patients you're operating on have had surgery or already.
Sorry, Jeremy. Can you repeat?
So, when you were based in Bologna, of the workload that Bologna was receiving, around about 70% of patients had already had some kind of surgery before they came to you, whether that was open biopsy or so. Yeah. I think we're very lucky in the UK that our actual education is actually good for the likes of people like yourselves coming and talking to the spinal community, and the spinal community being quite small, because I actually, my experience is probably only maybe 10% of my surgeries have had somebody operate.
This is a cultural difference between English and Italians, and Italians are very difficult to manage. And this the very old question could sit down and debate, but since 1,000 years. You can read in the story that never happened. So, every surgeon in Italy, or at least 80% of the surgeon in Italy, they see something that it destroying a vertebra, and they try to do something without thinking that it would be better to send it to Luzzati or to Gasparini or to myself, and maybe they could find a different solution. And as you can see, not only in my papers, but also in the papers of Luzzati, that almost 70 to 80% of the patient had been already treated. And this means, obviously, everything much more difficult. And we have a series of Enbloc resection, excellent Enbloc resection indeed, with very poor result as had been already treated before. But culture and education is something which is very difficult.
But great food.
Yeah.
If I may add a few words about the genomics, because I brought this topic on because we do refer sarcoma patients to Genomic Tumor Advisory Board, and they are sequenced. And indeed, only 5% of all sarcomas would have actionable mutations, meaning that they would be referred to the clinical trials. And I'm not sure how well they respond to the experimental therapy. What I think is most important is the prognostic value of some of the mutations that we are yet to discover. So I may sound naive, but I would hope that particularly in chordomas, as Professor Boriani mentioned, it's such a heterogeneous group of tumors, and we don't know which one is going to respond well to protons, which one requires more aggressive surgical treatment. And maybe this is the answer that genomics will be able to question that the genomics will be able to answer. That's how I would say it, to be honest.
Yeah, but there's some work already been done with the single nucleotide 7 for chordoma, and so the deletion of with SMP7. But I mean, whether it really takes us away from saying I'm not going to operate on you because you've got a poor prognosis tumor, or I'm not going to offer something because of a poor prognosis tumor, is going to be going to be really difficult. And so we've started a project with Alison Simmons, who's actually a GI mesenchymal immunology lead for NIHR, to do some deep genomics on chordoma, and it'll be interesting to see where the application of those things lie. But I agree with everything that's been said in terms of how far away we are, I think, in chordoma than in solid tumor. But also just from a volumes perspective, like how many patients do we have to prove that this is going to make a difference? Because we have so few patients. We've only got relatively small international groups that can monitor. The treatments are so heterogeneous: intralesional surgery, true Enbloc surgery, Enbloc plus protons, neoadjuvant protons, post-adjuvant, that all of those different things coming together. Of your 40 chordoma patients in the UK per year-ish, of all of those things that are so heterogeneous, then you got your genetics on top of that. Well, what led to the bad outcome? Was it the bad surgery? Was it the bad whatever? What led to the bad? It's very difficult to prove that. Really valid to research it, but I think certainly in my career, I have zero intention of being around still working whilst this is when somebody has decided this. So Martin, your hair is still a lot more present and your face a lot more youthful. So you may still.
Can I interrupt there, please? Can we hear a bit more from Dr. Boriani, please, or what he thinks about your points that you raised?
Stefano.
Sorry, I don't see.
And your thoughts, Stefano, about the role of the genomics in terms of where you think that may take us in the next 10 to 20 years, whether you've got any feelings about where that might take us?
Unfortunately, I have no possibility to give you a real answer. We are studying together in our knowledge forum group, and I think that this is really a possible answer to all our questions, but indeed it's not something that will be realized in a short time. That's the problem. So the patient asks us what to do, and we are not able to give a real answer.
There is a very interesting question from Mike Gravett regarding the counseling the patients preoperatively. I can see that Professor has replied, but if we could learn your thoughts, Prof, regarding this. He's disappeared, I think. I think it's a big thing, counseling these patients for life-changing operations, aiming for cure. I'm pretty convinced Jeremy and Kat, you must be finding it difficult.
Stefano, you back on. Sorry, we lost you a second. Martin was just asking in terms of Mike Grevitt's question about how do you counsel patients?
Well, I spend a lot of time with the patient, and obviously every patient is different and every tumor is different. And so, for example, last week I spent 3 days for a young woman, and she has a chordoma below S3, and she is really one of the few cases in which I proposed the surgery, even if I had referred her to the carbon ion center, and they said to do carbon ion, but if we don't do Enbloc resection in a sarcoma, in a chordoma below S3, I don't think that surgery will never be done again. And so I think that every patient is different. Every expectation is different. We must be very honest to tell them what we really can do, what we really can offer, and balance with what they expect. And indeed, if I had a huge chordoma to L5, I would prefer to have carbon ion, no doubt. But now I know that after 5 years, the tumor will be there again and will be growing. And so I have to look for another radiation. I have no patient who was not growing after 5 years. And so we were enthusiastic some years ago, but now we are not anymore, as all the patients are, the right term is not recurrent, as the tumor is always there. But there is necrosis, and there is growing, and there is pain.
The Boston team have some data that does stretch beyond 5 years. That is slightly more encouraging than that. But yes, there's always going to be some group of patients, but I don't think every patient at the end of 5 years, in our experience with the team in Boston, was either recurrence or necrosis. Just to put a slightly more positive Friday afternoon spin on this.
I'm very skeptical, as you know, how we can say this, as we can take the dimension of the tumor. We don't understand really which are the real dimension, which is there is necrosis or not necrosis, and then the cut of the MRI is a little bit different. The tumor has pain, the patient has pain, there is a pathologic fracture. There is always something that is wrong. So obviously it's better rather than to be on a wheelchair without any control of a sphincter. I agree with you, but there is not the solution. The tumor is still there. The tumor is still growing. And a few years ago, I was very happy, but now I have no patient who has no problem after carbon ion alone.
In your patients,
and
you
I
deal
see
with
the patient,
people all over the world.
Jeremy, the difference is that I see the patient. The patient come to me. It's not just a phone call or a letter. No, the patient come to my office, and I see all my patient. And that the difference with the great tumor center, when you send a letter, ask the patient who is in another country and say, how are you? You can send us the MRI. No, I see the patient, and I see the patient who say, but you told me that this was a solution. Now I have pain. And now you see in the MRI, and you stay 1 day in front of the MRI, you compare, and you see that indeed, maybe it's not growing in the part, but it's growing in another one. And then it's difficult to decide what to do.
And do you find, given that you have a very large international, you've brought people, certainly when you're in Bologna, from all over the world, is that the bit that Mike was asking about in terms of the counselling? Do you find that that's cultural as well, that you end up with different patient groups who would be more keen to go down an aggressive surgical path, or would that be something that you just think that the inherent nature of a patient is to want to have cure, have the big thing?
Every time I see a patient with a chordoma, I refer this patient to a radiation oncologist able to perform carbon ion. I never take a decision alone, but we have no possibility to organize the board, and the same in Bologna, and maybe Luzzati has the possibility to have a board, and they have a group with the Istituto dei Tumori in Milano. They have a special protocol, but I don't think that the results are different from mine.
And Catherine, in terms of the UK, because you have essentially, we've talked about this before, almost like a gatekeeper role to the proton, so you're getting a lot of the referrals. Is there a way that we can drive that collaboration and cooperation across all the sites? Because there'll only be 2 proton centers by the end of this and 1 proton panel. Do you think that there's a way of us streamlining the process and making the UK really a sort of leader at this, because we're small but highly populated?
Well, just in terms of the numbers that we seem to be getting just now, because the access. So, some of the difficulties in some other countries is that people can't access their something like protons because of financial difficulties, insurance, or that the pathways aren't paved for them, as they are in the NHS. So the patients have to seek out protons or carbon. So yes, in that sense. Number one, and number two is we don't have a private area in Manchester, but there will probably be one in London. So I don't know how much work they're going to do for international patients. But what we would really like to see, now that we're a little bit further down the line, is actually not having to have the proton panel to the same degree, and the patients come more directly to the MDT, and having those discussions more preoperatively. But we can't really do that without the NHSE accepting that. We definitely can't do it without UCH being up and running, not just open, but up and running a bit.
And your experience, Stefano, in Italy, is there any attempt to create a national framework, or is that a million miles away?
That's difficult, as there is an attempt to create a framework, but there is not the support of a scientific society, so it's just an attempt of a few group of people. But the center for carbon ion and prototherapy are only 2 at the moment, maybe 3 in the next future. So it's relatively easy to have contact with them.
Yeah. So we're coming up. There's not been many. I think there's a lot of questions that have been asked directly to Sachin, but we haven't got them on the actual chat group. So it's really difficult to know whether we're missing specific questions because they
can you not see the chat? Jeremy, can you not see the chat?
I've got very few questions on.
So there is a question from Ray Ross. How much cooperation is there?
Yeah. I've replied the Knowledge Forum, and I think the Stefano's may have replied. So, Stefano, would you like to talk about the Knowledge Forum, the Petron study?
Well, I think that since more than 20 years, we have the great opportunity to meet each other. I am speaking on a group of surgeons, radiotherapists, and medical oncologists, specifically dedicated to bone tumors. First, we had a group sponsored by Johnson & Johnson, and later on by Medtronic, and later on in the Knowledge Forum under the umbrella of the BritSpine. But we are always the same people. And this was a great opportunity, as we can share experience, and we can debate, we can speak the same language, and we could write a very, very interesting paper. We did good researches, good literature reviews. So I think that we could promote the knowledge on bone tumors. And this is a big amount of literature which has been created by this group of people. I think this is really we did something very good, I think, with different names as
yeah, but the leadership
oncology study group, and then tumor oncology, and global tumor spine group. and then our Spine Knowledge Forum. So, but we are always the same people.
Yeah, I think the leadership shown by yourself and Peter Varga and Zia
the
over
great
those years
leadership was
key.
by Charles Fisher and now
Charles,
also by you. You are doing a great job in this.
I think the leadership and the setting up of that framework by yourselves and Charlie, etc., have been really key to where we take this. So we're coming to the end. Sachin, would you like to wrap up as the big boss?
You guys are the big bosses. I'm just admin back here, but unfortunately, can you hear me? No, unfortunately, Mel's mic and camera didn't work, so I had to step in. I was just put in the spotlight. No, anyway, I'm happy to. So thank you, everybody. Catherine Coyle, thank you very much for joining in after your busy day.
My pleasure.
Jeremy, Marcin, thanks a ton for the afternoon and all the hard work you put in. And nevertheless, the most important thank you should go to Dr. Boriani. Fascinating talk, thoroughly enjoyed it, learned a lot, and really, wish it was a face-to-face meeting. I'm sure we would have all gone out for a drink after this and spent a little bit more time discussing everything and all the nuances that you picked up on. So thanks a ton. And I would like to thank AO Spine again for facilitating this session. And I think at this point, I'll hand over to Patrick to do the close for this. Thank you very much, everybody.